again is an interesting one by Dr. Avinash. He'll be speaking to us about how the vein occlusions in younger people are different and how do we go about investigating them. Dr. Avinash?
Yes, sir. Right. Thank you, sir, for giving an opportunity and inviting for your session. And we all know when are my slides seen?
Yeah, seen.
Yes.
Your 18 clinical pearls are seen.
Yeah, let me complete before the buzzer goes. So when we all aware that when retinal vascular occlusion in young means we are looking at a profile of individuals or populations less than 40 years. And when we have this younger population, we must also know that they would present with various clinical spectrum, and the approach also has to be different than the patients who have vein occlusions when they are elderly. Most commonly caused by diabetes, hypertension, dyslipidemia, atherosclerosis. So I will take through this entire presentation with just 18 clinical pearls. And the first is what is the difference between the type of hemorrhages in retinal vascular occlusion when we compare from an elderly to an young. And we all grew up with understanding that superficial hemorrhages are the commonest clinical manifestations of what we get to see in a patient with retinal vascular occlusion. But here I would like to draw the attention that in young, there may be a higher instance of deeper intraretinal hemorrhages when what we can see on the left-hand side compared to superficial hemorrhages. And why so? So what is the cause for the deeper retinal hemorrhages compared to superficial hemorrhages? So the typical block, the hypertension associated, the age-related, there is an acute rise in back pressure that causes ruptured superficial capillaries resulting in flame-shaped hemorrhages, where that's not the case for a deeper retinal hemorrhages. The deeper retinal hemorrhages usually is caused by gradual raised pressure or for vascular endothelial injury. So this is how the difference of the deeper and the superficial hemorrhages do happen. And to add a few more points, when you see a patient who has deeper hemorrhages, suspect the underlying etiology to be systemic, and it is more profound and of chronic nature and not acute nature. So like what I mentioned earlier, the causes of vein occlusion in an elderly and young are different. But when you have the age less than 40 and we subdivide them into the pediatric age group and the 18 plus age group. So in pediatric age group, we have the cyanotic heart disease is something which we have to keep in mind, which never strike us when we see a vein occlusion. Apart from that, we have the inflammatory etiologies, the aplas and Behçet's, though rare, the children can present with Behçet's as well. So rarely you have an inflammatory etiology as a cause in that age group, other than or an infective etiology in that age group. But do remember, it's a cyanotic heart disease with elevated hematocrit value is something which we have to concern at the pediatric age group. Having spoken about the pediatric age group, few more diseases just gets added when a person crosses 18 plus. And there are hypercoagulable states where protein C, protein S deficiency, blood dyscrasias like leukemias, polycythemias, again, a host of inflammatory conditions. You have the primary APLA, the secondary APLA conditions, infections like tuberculosis and toxoplasmosis, and drugs like OCPs and hormones can also come into play. So, few clinical signs which I would like to highlight is, apart from the age, which is of significant concern in people who are less than 40 or even more than that as well, is the dark column of blood. Is always suspect in hypercoagulable state whenever you see a vascular occlusion, venous occlusion with a dark column. So check for protein C and protein S deficiency, especially if they come with the disc edema. And the next condition, like what I mentioned, is leukemias, apart from protein C and protein S deficiency. And the mechanisms by which they develop vein occlusions is because of raised blood viscosity, increase in WBC and platelets, and above all, because of optic nerve infiltration. So many a times, both the acute and the chronic types of leukemias, both of them can cause vein occlusions, more so common in the chronic ones. And how does clinically we can identify that if there is a venous occlusion is because of leukemia or not, is the presence of rod spots, dark blood columns, perivascular infiltration which does not leak on fluorescein, and the sudden appearance of NVE. So these are the last two are something which is very important. The perivascular infiltration which doesn't leak on on fluorescein, and the sudden neovascular appearance is important. Now, moving on from, I just discussed about protein C and protein S deficiency, then the leukemias, the inflammatory causes. Top among the list are tuberculosis, second is toxoplasmosis, and third is the Behçet's disease, are the three most common cause of retinal vascular occlusion when we see patients with posterior uveitis. And some interesting clinical findings by which these retinal vascular occlusion manifest in presence of retinitis is, if you look at the picture on the top, on the left side on the top, the retinitis can be totally engulfed, or the vasculitis can be totally engulfed by the retinitis. And the picture in the bottom, in the middle, you will be able to see distal to the vasculitis, you will be able to see a retinitis patch, or there can be a retinitis patch proximal to the area of vasculitis. So these are the three ways by which one would be able to associate a retinitis with vasculitis. Either it can engulf it completely, or can be found distal to the occlusion, or even proximal to occlusion. So is it important that we have to do a detailed peripheral retinal evaluation in case of retinal vascular occlusion in young? Yes, sometimes these patients can also present with exudative retinal detachment, and sometimes we'll be able to pick up an AV malformations which can cause venous occlusions in these patients. And sometimes even a very careful examination of epipapillary and peripapillary loops is also important to find out an etiology for retinal vascular occlusions. So having understood the various clinical manifestations, if a patient presents with AV malformation, it is important that we have to image the brain, because some of these patients can present with similar malformations in the brain as well. Now, we spoke about vascular occlusions, but in this age group, or even in elderly age group, if a patient presents with bilateral, it's a red flag sign. And in an younger patient, always suspect leukemia. And another etiology which one would consider is Waldenstrom's macroglobulinemia. An additional point which I would like to mention here, a clinical point, is patients with Waldenstrom's macroglobulinemia rarely present with macular edema. So if a patient has a central retinal vein occlusion and does not have a macular edema, consider two differential diagnoses. It could be a cilio-retinal artery occlusion, or a patient can have Waldenstrom's macroglobulinemia. So another manifestations, we consider rod spots, we considered bilaterality, we considered darker blood column. One more considerations, especially in a young, is coexisting arterial occlusion. So when a patient has a coexisting arterial occlusion, think about an etiology of either primary aplar or a secondary aplar, and rarely primary or secondary hyperhomocystinemia can also cause an associated arterial occlusion. So my 14th pearl would be in terms of if a patient presents with bilaterality or can have multiple recurrences, like one eye can have a branch retinal vein occlusion, other eye can go on for CRVO, and then can develop another vein occlusion in some other quadrant. So always suspect the underlying systemic etiology has never been diagnosed. It's something which we have to go behind it. OSA, obstructive sleep apnea, is one such etiology which we have to consider, especially when there are recurrent vascular occlusions. And what are the outcomes? The important is especially in a young, when we know what could be the cause, many of these vascular occlusions resolves when the underlying etiology has been treated. And this is one such patient who had a venous occlusion because of secondary hyperhomocystinemia. Vitamin supplementations because of the micronutrient deficiency was all what was required for the condition to resolve. And this is another patient who developed a venous occlusion because of atypical optic neuritis, and for treatment of optic neuritis itself had resolved the macular edema in this patient. Now, I did discuss about, the outcomes would be primarily influenced by the underlying etiology, and many times treating the underlying etiology itself helps in the resolution of vascular venous occlusions. Now, we know that anti-VEGF is a primary treatment in most of the cases with venous occlusions, but there is something which we have to understand, especially in young. We have to have some sort of an judicious use in young, especially when we are dealing with an aplar-like condition where sometimes when you have a coexisting arterial occlusion, injecting anti-VEGF can worsen the venous occlusion or further enhance the arterial occlusion from happening. So that's why we have to exercise a concern, especially when you're dealing with an SLE or coming with a secondary aplar or a primary aplar. Don't go away right and injecting an anti-VEGF in these patients. And another indication where we can still inject anti-VEGF apart from CME, NBI, NVD, or NVA is a presence of exudative retinal detachment. So if a patient presents with exudative retinal detachment, that be one more indications where we can go ahead and. So I did finish my 18 clinical pearls. Just about red flag clinical signs: deeper hemorrhages, darker blood column, bilateral occlusion, rod spots, associated arterial occlusion, recurrent occlusion, and absence of macular edema are important red flag signs. And for evaluation, those who we consider the block at the AV crossing, then we know the etiologies of hypertension, hyperlipidemia, obesity. But those which are not at AV crossing have to have a detailed evaluation. So outcomes primarily depends on the etiology, treat the underlying cause, and be judicious of using anti-VEGF, especially in an younger individual who presents with vascular occlusion. Thank you very much for your patience.